to join. And I'll go ahead and start, and just a huge warm welcome to all of you for taking the time out of your really busy schedules to be with us today and to talk about the really important topic, what matters, working together to address the biggest factors impacting health. And my name is Sheila Smith, and I'm with the Engagement and Patient Experience team. And it's really our pleasure to be the hosts for this session today. We're going to start off today with a land acknowledgement. We acknowledge that we are gathered virtually today on the territories of Treaty 6, Treaty 7, and Treaty 8, and Métis Regions 1 through 6. These territories are home to many Indigenous peoples, including the Blackfoot, Cree, Dene, Saulteaux, Ojibwe, Stoney Nakoda Sioux, and Tsuut'ina peoples, the Métis Nations of Alberta, and the 6 Métis settlements. We acknowledge and respect the treaties that were made on these territories, and we acknowledge the traumatic and painful impact of colonization on Indigenous peoples. And we recognize that eliminating racism in healthcare is a crucial step on the path towards reconciliation. And we dedicate ourselves to a collaborative partnership with Indigenous communities, guided by patience, understanding, and a commitment to reconciliation. So just a few quick reminders. Today's webinar is being recorded and will be posted for viewing later. Your microphones will be muted, but you're invited to use the Q&A function as a way to pose questions to the presenters, and they'll be addressed at the end of the presentation. Feel free to use the chat box to share comments as we go along. And just to note, in your, you'll see in the chat box either presenters or everyone. So just make sure you're selecting the right audience for your chat. And if there's more than one of you, please just chat in the number of attending so we can keep track of folks. A quick introduction to who we are. If you haven't heard of us, we're a provincial team within the quality portfolio here at AHS. And our commitment is to bring leading practices, content expertise, and our passion and your passion to patient experience in AHS. And it's my pleasure today to warmly welcome our wonderful panel. And we've got Shauna McGann, Scotty Cooch, Lisa Allen Scott, Joanne Stewart, Catherine Gagnon, and Charlotte Thompson to share their lived experience and wisdom today. And you'll learn more about them through their bios, which will be posted in the chat as we go along. So get your questions ready, get your thoughts going, get your mind working, and we welcome Shauna to start us off.
Thank you so much. Great to be here. It's just a wonderful opportunity to talk with all of you and with our panelists today who represent a larger team who've worked over the last 4 years on what we affectionately call reducing impact on financial strain, or RIFS for short. We want to hear from you throughout this session. So start by telling us in the chat, have you provided patients or community financial strain supports within your setting? So kind of pop a yes or a no in the chat box. And then if so, what does that look like for you? So as you're doing that, I'm thrilled that we have here today with us our sponsor and our visionary behind this work, who's able to join us and share a few words to start us off. Dr. Laura McDougall is Senior Medical Officer of Health for AHS, and she's the Senior Medical Director for Provincial Population and Public Health. Thank you so much, Laura, for joining us. Over to you.
Thank you so much. I'm absolutely thrilled to be here and thrilled to see the interest in this work. I thought I'd just give just a few thoughts about how we got here and some of the thinking that went into this project and this collaboration, and hopefully this way of working that will carry us forward. As we were thinking again about, what makes Albertans healthy, what are those actual conditions that create health, and what creates those conditions that make it possible for us all to achieve our fullest health potential. We were really reflecting on the fact that, again, the determinants of health cause about 75% of our illness, or contribute to 75% or so of what makes us healthy and well. And we were thinking all the time and effort that we spend in public health and population health, working with partners in the community on creating those conditions to make it easier for people to be healthier. What would it look like if we really partnered effectively as possible with our primary care partners to try to tackle issues like financial strain from both sides? So we really work together to be thinking about how do we take action with patients in our clinics and with our patient panels, while at the same time taking action with our communities, and build a really seamless connection between the things that are causing ill health, the solutions that can be provided in that brief period of time that patients spend in the clinic, but such important time, and then be connected seamlessly back to the resources and the environment in their community to help continue the work of addressing those underlying factors. We know from the literature that financial strain, or not having enough resources to make ends meet, is the most important predictor of health outcomes. So we decided together with primary care that if we were going to make a dent, that was the one that we were going to work together on. So we looked again at the literature, and we're again very fortunate to be able to stand on the shoulders of many giants before us, including colleges of physicians and surgeons across the country who had already piloted a resource that allowed primary care to identify patients who were struggling with financial strain. And then at the same time, to actually build some tools to support clinics and the actual primary care environment of what do you do when you've identified patients that are actually struggling? What sort of changes in practice? What sorts of ways of being within the relationship with patients? What sort of connections to communities can we make? How do we change what we prescribe? How do we really change that whole narrative? At the same time, we are also able to leverage the work that public health had been doing around healthier together communities, and build a whole way of working with communities on creating those resources, those partnerships within the community, so that once patients were finished with their clinic appointment, they were able to be connected to resources in the community, while at the same time fostering a whole, hopefully, change in approach to financial strain at the community level. And the really exciting opportunity here was that as patients were being identified with financial strain, able to learn from that that lived experience, and actually inform how the communities were going about addressing those conditions within the community environment. So that was really the idea behind RIFS. It was hopefully a way of working that could be applied to other determinants of health, other issues like domestic violence, other issues like education, all sorts of other issues that we know are so important for what actually contributes to health at the end of the day. So with that really was the thinking behind this. And again, one of the key goals of this whole project was that we learn how to work between public health and primary care in a whole new way. This is something that's been spoken about in the literature, in conferences and academic environments in the healthcare system for decades and all around the world. And I really want to take my hat off to the amazing people who were able to actually bring this to light. And again, a whole different way of working between public health and primary care as well. So we have a lot to be thankful for, a lot that you've built, and a lot that we really can use to take this forward.
Thank you, Laura, for those great words of introduction and for your leadership in this work. So part of this project was to really amplify voices and experiences. So 13 digital stories were created. And we're going to watch one of those today to help ground us in the experiences of people with financial strain. And then we'll have the privilege of taking a deeper dive with the author of this story. So share with us in the chat your reflections and what resonates with you as we watch together the snowball effect.
I have lived in the same home since 1967. It has seen me through good times and bad times. Times when I had plenty and times where I had little. And recently, numerous health issues. Fibromyalgia, amputation of my toes due to a blood clot, ovarian cancer, PTSD, and all the financial stressors that go hand in hand with serious health issues. The one constant I have had through all the ups and downs is my home. Even though I'm on a fixed income, I was making it work until one afternoon I received the phone call. You owe the city $9,000 in property taxes and you have 12 months to pay or we will auction off your home. The image that struck me in the face was the farm auctions in the 30s. People forced to watch their life slowly erased and sold with every gavel strike. That was not going to happen to me. I was able to take a side gig to make the extra money, but with my pension and disability, I'm limited in how much I could make. And then COVID happened. The side gig disappeared overnight, and because of my fixed income amount, I didn't qualify for any COVID financial supports. So I kept paying bills as much as I could, relying on credit cards for food and medications, often making the decision to buy one or the other. I connected with some supportive services and was sent gift cards and food hampers, but the snowball had started rolling and there was no stopping it. One afternoon, there was an envelope taped to my door as I went out to pick up my medications. This time, the bank was foreclosing on my house unless I could come up with $25,000 in 6 days. Standing in front of the pharmacist, I had to tell him, I can't afford to buy my blood thinners today. You can't go without them. I know. I have no money, so what do I do now? He paused for a moment. Well, you can have these 20 for free. Will that get you to your next check? The snowball continues to gain momentum, and I'm acutely aware of how close I am to losing everything. I never thought that I would have to make choices between essential services like electricity, gas, phone, internet, medications, and food. Yes, a house is an asset, but where am I going to live in the city for half the value of my home? It feels like there's no way out, and there's no getting away from it. I want to live a healthier life, but right now the food insecurities and financial insecurities are overwhelming. I think it can be easy for healthcare providers to see a health problem and offer a solution, but in my experience, it's never that simple. Living a healthy life goes well beyond the hospital walls.
Wow, it's such a powerful story every time I see it. I invite your reflections in the chat. But now I want to just take some time to chat with Scotty. Scotty, so many people have been moved by your story, and we're so grateful you could join us today. Help us understand further how financial strain has impacted your health.
Well, it's not easy having a financial gun pointed at your head, which is the situation has gotten worse. I still have a roof over my head, but I was forced to, without going into a lot of details, we don't have enough time. basically I had a financial gun pointed to my head, and I still have it pointed to my head. So I still am on the precipice of potentially losing my home. With the situation, it's living with PTSD every single day, and you can't get away from it. And yes, I did have help. I'm a part of the clearing up of property tax consisted of an amendment to my income tax. And I had to wait 6 months and write my MP to actually get it pushed through in time. But it was every day calling resources, and resources are out there, and bless them all. A little known fact though with the resources is that within 2 days of the beginning of the month, those funds are gone. So that's something to keep in mind for those of you that are on the call, is there are resources available, but the funding is gone. It's in and out. How this impacts your health, it's like living with PTSD that you can't escape from. My quality of sleep has suffered, which leads to increased use of sleep medication, which is frowned upon by the College of Physicians and Surgeons. And they have, I have managed to cut back. So for anybody that's with them, but they've labeled my doctor as a bad doctor when in fact it's polar opposite. I'm very fortunate to have a great healthcare team that is in my court, but it affects everything. It affects your ability to think critically. It's overwhelming. You have no sense of direction. It's very similar to a spider web. So lack of sleep, PTSD, not being able to afford healthy food. You're limited to what you get from food bank or other options. It's highly processed, which had led me to an increase in blood pressure, which now I have to take blood pressure medication, which I might not necessarily be able to afford. So there's the risk of having a heart attack. If I'm sleep deprived, it affects the pain that I experience in my foot. So I have to increase my pain medication. It's insidious. And it's like being in a nightmare. If anybody on the call, y'all watch Stranger Things, it's like living in the Upside Down.
Wow.
Really, truly.
Yeah. Oh, I'm sorry to hear the challenges, but I'm intrigued by, you mentioned that the healthcare team has been incredible. Can you tell us a little bit more? What does that look like? I think we'd all be kind of interested to better support people with financial strain like yourself. So what does that look like for you?
I mean, it's hard for me to say in my situation because I am spoiled. I have the best doctor in the world. Hopefully she's on the call. Big shout out to my doctor. You know who you are. I have a phenomenal internist. I have an amazing endocrinologist and a great hematologist. So I'm spoiled in that aspect. But I guess from the patient's perspective is, really, we're not an interruption to your work. We're the reason for your work. Y'all wouldn't have jobs if you didn't have patients. So for me, if I was to go into, and I have actually gone into a walk-in clinic recently, I had to. But you have to, as a healthcare provider, you have to, in a very short period of time, create an environment where the patient trusts that they can confide in you and be honest with you. And it's that safe space because I've had the same family physician for many, many years. We've developed a rapport. And the one thing that as a patient that I keep in mind when I go and see my doctor is at the end of the day, regardless if you have a PhD or however many initials you have after your last name, we're all human beings. So even though my doctor knocks on the door and says, "Hi, how's it going?" I'm like, "Good, how are you?" The other day I went to see her and she's like, "Meh." And I'm like, "Just meh?" And it was an opportunity for her to vent. And she's like, "Well, this is your appointment." I'm like, "Yeah, but you need to vent too." And so at the end of the day, we're all human beings. So,
Yeah.
Like, don't forget that as a patient and don't forget that as a provider. So, it's actively listening and engaging that patient, creating that safe space where they can be honest with you and say, like, "Okay, you've had a blood clot. We're going to give you we're going to, prescribe tinzaparin. And if you don't have coverage, it's $1,700. Well, I can't afford that." So then you have to quickly think how to come up with a solution. Contact the pharmaceutical company and see if they have compassionate. That's a big chunk of change for somebody. So, it's actively listening to what the patient is saying.
Yeah. Wow. That's so good. Thank you so much, Scotty. Really appreciate your wisdom. And we hope you're going to stay and join in the panel. So if others have questions for Scotty, put them in the Q&A. But I want to turn over to Lisa and just, Scotty's really highlighted some urgent need for this work to really continue and to grow and to happen in our province. So can you just tell us a little bit more about why did this work get started?
Sure. Thank you, Shauna, and thank you, Scotty, for sharing your story. And I agree. I think it's really the stories and the lived experience that makes this work so important. When Laura opened us up, she mentioned the idea that over 70% of our health is shaped by the places where we live, by our relationships and by our circumstances. And there's a growing recognition, of course, that we need to think about how we can improve those environments. That includes our healthcare environments, our communities, our workplaces, and our schools in order to be able to promote health and prevent disease, and really thinking upstream around social determinants of health like financial strain. But we also know that our healthcare system is currently designed to operate primarily in a reactive mode, addressing illness, injury, and mental health conditions as they arise, rather than working proactively together with communities and partners to create conditions that keep people healthy and making those opportunities to stay healthy. So in response, the Reducing the Impact of Financial Strain project was founded on this understanding that we need to work together in order to make a difference, understanding how we can build those strong partnerships between primary healthcare, public health, and community to be able to address social determinants like financial strain. It was an initial grant opportunity, but it was a great opportunity to start to bring different teams together and to really learn from patient experience to be able to understand what a collaborative model could look like. So within the Collaborative Financial Strain project, we tested and piloted with community teams and PCNs, really looking at connections and how to work with primary care, public health, community agencies, and organizations. The project involved screening in primary care to identify those who were experiencing financial strain. So asking the question, do you have challenges making ends meet at the end of the month? And then making sure that there were strong navigation pathways to existing community resources, and also leveraging a community development approach, the Alberta Healthy Communities approach, to be able to create partnerships in communities and create new resources and assets in community to support those experiencing financial strain. It really was a locally driven approach. And I think this is important around the why, understanding that each community, each patient, each PCN is unique. So we need to understand how to connect resources, connect people at the local level to really make it effective. You might be curious about, what was kind of done within the Reducing the Impact of Financial Strain project around where did we work. So from a PCN perspective, we worked with 5 different primary care clinics, and though they partnered with 4 different communities and a number of different partners. Across the 5 clinics, the team screened over 620 paneled patients for financial strain, and over 30% of them screened positive. From the screening, we also know that about 67% of patients who screened positive did accept a referral for additional support and navigation to community resources. And from a community's perspective, there was also opportunities to make some enhancements to the local environments to support those experiencing financial strain. So the community teams, which there were 4 different community teams, designed and implemented over 60 strategies to support implementation of community level initiatives, focusing on strengthening collaboration, increasing awareness and socializing, and reducing sort of the stigma around financial strain, increasing access to the resources, tools, and supports that we need, as well as increasing our knowledge about what to do around financial strain. I think the need also from your question really comes back to the idea of how do we create a sustainable approach to collaboration? So not only with regards to, what did we do, but how do we work together? And there was a lot of key learnings that came out of the project with regards to how do we make sure that we have the appropriate partners represented? How do we create open communication channels? Clearly define roles and responsibilities, create a shared vision, ensure that there's leadership support and relationships, and that we have a collaborative mindset. But overall, coming back to the why of this, I think we all know that keeping people healthy and well in the community is critical for the sustainability of our healthcare services. And we can't address social determinants of health in silos. We need to work together across our sectors, across the places where we work to support Albertans to make a difference. We also need to shift our mental models. We need to build empathy, and we need to reduce the stigma of financial strain so we can really understand and impact what influences health. So RIFS is an exciting example of how this is possible from a system, community, and patient perspective. But I think in the go forward, we really need to think about how we can all take action on the social determinants of health, because we all have a role to play.
Yeah, so true. And it's exciting. We've got now some of our panelists here that have that frontline experience. And Joanne, you were one of those local leads that Lisa mentioned, to bring together those local resources and groups that elevated health. So tell us a little more. How did you bring community and healthcare providers together to understand the needs and inspire action?
Good afternoon. Thanks, Shauna. And RIFS was an incredible experience for me, for working with Frontline. And I'm a health promotion facilitator. So my role was to encourage Vermilion, the community I was working with, in the community stream of the RIFS project. And our role is then to build capacity to improve factors that influence population health outcomes for community. So when I say community for us, it's those social service agencies, faith groups, not-for-profits, municipal government, any of those sectors of health that are present in community. And to do this, we use the strength-based healthy communities approach to engage community stakeholders in assessing what community resources there were available and identifying any priority areas that we came up with for action so that communities could be healthier places to live. And we started out by holding a community engagement session with about 30 community stakeholders in attendance that were interested in the project, interested in addressing financial strain in Vermilion. Our initial partners were family and community support services, Kalana Country Primary Care Network, and AHS. But as the project got going, we Ministerial came on board, Food Bank, Hearts and Hands, Lakeland College, Victim Services, groups such as that have an interest in reducing financial strain in community. And as we did this, then we took a deeper look at what assets there were in the community that could possibly help and do help with financial strain. And as we did that, we discovered that there's resources that we weren't really aware of before, such as transportation options, things like that. So yeah, it was a really interesting process. And the most impactful activities that our group understood really helped us to build empathy, as was said before, so that we could really truly understand the experiences of what caused pain and what caused gain for those living with financial strain. Our group, as we started out, we thought we knew what it was like to live with financial strain, but as we became more aware of our own biases, we realized that we needed to listen more and learn from those with the firsthand knowledge of financial strain, and we needed their voice at the table, and ways to amplify their voices, to be responsive to what it's like and how to make a difference in their lives.
Yeah, so tell us a little more. What were some of those impactful activities that you did?
Well, one of the first things we did when we started out was a poverty simulation. And some of you may have heard of that before, but for us, what we did was we had 80 Kalana Country PCN clinic staff and community members kind of combined together to do a poverty simulation in the hall in Vermilion. And after it was over, the group shared their experiences of what it was like to live in those 3 10-minute pieces of living with financial strain. And people spoke of how exhausting and challenging it was to access all those services that they needed to meet the needs of their families. And we have digital stories that talk about that as well. But for me, some of the most heart-wrenching comments that came out was from a participant that talked about playing the part of a 15-year-old daughter living in a family. And they said that they talked about how they felt like a mom, and they struggled really to focus at school because they were thinking about all the challenges that were happening at home, trying to make ends meet and that sort of thing. So for myself, we all had a part to play. And during the poverty simulation, I played the role of a single father. And we all had how do I want to say, pieces to play and that sort of thing. And so I had a teenage daughter and a young son in the poverty simulation. And I worked, but my income wasn't enough for my family to make ends meet. And many of the extra supports that I needed to access to help my family were only available during the same hours that I worked. And of course, my workplace wasn't really very happy with my having to leave early or take time off to go in and access these services or make appointments, things like that. And even though I had a job, I didn't have benefits. So things that other people may not have to pay out of pocket for, I had to pay out of pocket for. So that just sort of increased the stress. And even though I knew how important prevention and looking after my health was, I didn't take the time to do that until the very end of when I was in dire need. I didn't do it until then.
Yeah.
So that was part of that poverty simulation. It was an incredible experience.
Yeah, incredible. Yeah, so many gems there, isn't there? I think a lot of head nodding. So Charlotte, your PCN, your primary care network, collaborated with the community team that Joanne and others have described. As a clinic manager, how do you see social determinants of health impacting patient care?
Thanks, Shauna. So I guess my view is around the clinic itself. And what I found is if providers didn't take time to look at the holistic, patient-centered care, they wouldn't get the whole story. And so if you don't get the whole story as a healthcare provider, allied health worker, you might become really frustrated and label patients as non-compliant. But that's because they're not meeting your care goals that you want to see. It's not that the patient wants to be non-compliant, that's so far from what the actual truth is. Patients struggling with social determinants of health don't purposely choose to not take their medication or to follow up on the things you may have given them as ways of helping them. The reality is once they walk out of that appointment, their mind shifts to, where am I going to get food? How am I going to pay my bills? How am I going to get clothes for my kids or myself? Never mind going to get new medications and trying to figure out how to take them. Poverty inhibits a patient's ability to eat healthy, take medications appropriately, and can cause poor health outcomes that may impact multiple generations, not just one. But by what we found was by making one small change to our appointments, and that was just right, asking patients if they were having difficulty making ends meet, and then trying to look at ways that we could help them. And so the way we did that at first was we started really small, but it is just small steps that will help these patients. And then what we found is when we can navigate resources of negative social determinants of health, there can be a significant impact in population health outcomes.
Yeah, so dive deeper into, like, how did your team make this part of the patient's medical home within the clinics?
So yeah, one of, like what I was saying before, one of the biggest advice that I can give to people is to start small.
Mm-hmm. Yeah.
The other thing that I found was because our PCN has been part of a lot of projects, stop calling them projects.
Yeah.
Say it's a program, because otherwise people will make the change temporarily and then go back to the same way they were doing things before. The other thing we did was really reassure the patient, like the physicians and the allied health workers and the clinic staff themselves, that asking a simple question doesn't mean you have to fix it. It's that the patient can know that we care and are trying to find out ways to help them with maybe giving them samples of medications that if they can't afford or things like that. So basically our PCN started reducing the impact of financial strain program in 2019 late. And we took one afternoon week with one physician in 2 clinics. So we did Viking and Vermilion. And those physicians started asking each patient that was coming in the afternoon if they were having difficulties making ends meet. The one thing we found was that we started by asking people, like giving them a questionnaire in the waiting room, and patients quickly stressed to us that they didn't feel confident or didn't want to answer that question out in the waiting room because they feared somebody might be looking over their shoulder, and they didn't want to have that exposed to the whole community, especially since we're smaller communities. So what we did then was we laminated it and had it outside of each physician's office. And then when the MOA would room the patient, they would give them the one question and they could mark what it is, and it could be cleaned off at the end for the next person. What that did was enabled the physician, when they come in, to see that their patient might be struggling and to have that conversation with the patient while they're sitting there. That changed really quickly too, like from one physician to all of the physicians in Viking within a month. We're asking every patient So yeah, like it really did take off in one area. In our other community, the physicians and the staff there were a little concerned about what to do after the fact. So it took a little bit longer for them to take off. But the other thing we did was we spread that to our geriatric program and to our patients coming in for Dr. Pocketer did a PACT program. So patients coming in for surgery. He started asking his patients around that, and the foot care nurses started asking every one of their patients too, because most of them were diabetic and had some problems with possible wounds. And
So what about now? What are you doing now? Has that continued, and how has it grown?
Yeah. So now, when RIF's grant was finishing up, our PCN did an evaluation of the program, and we felt there was a gap of someone offering a warm handoff to the different resources in and out of the communities. Therefore, we introduced a position called a mental health navigator, and we used our surplus dollars to do a trial run of the position for 6 months. And we also went and to spread it to the rest of the PCN, we got t-shirts for everybody. I don't know if you can see this. Oops, I'm moving, am I? So our t-shirts say on the front, "You matter." And on the back, it says, "We listen." And so then we took each of our communities, the staff would wear that 1 day a week, and just opening up patients to ask us questions about what that means or what it was about, which was really great. We also started marking in our EMR systems, which is an electronic medical record, whether patients were positive or negative, so that if they had to go see a different physician, they could know that this patient was positive, and that, you know, you might want to look at what you're giving for medications or what help they might need. And after 6 months of that service, we reevaluated and found that there was a variety of reasons for referrals, and some of them being anxiety, depression, grief, addictions. But there was 36% that were attributed to RIF's positive patients.
Yeah. Wow, that's so good. I mean, that whole t-shirt you list, I mean, that's really reinforcing what Scotty said was so important in that care team dynamic. Thank you. Catherine, you were also part of a community development work in another community. Can you tell us a little bit about what impact you observed from community and primary care collaboration?
Okay, thanks, Shauna. Yeah, stories are very similar, but what I really realized about integrated social care is the impact and importance of partnerships, because these partnerships were what made this project a huge success and a success, because they were the foundation, and they formed what we called a multi-sector team, and this team worked together with shared leadership throughout the whole process and throughout all of the stages. So that was another huge success. Then this team, we called them community champions. What they did is we did as a team, we took a closer look of what financial strain really meant. Took a look a little bit at what cross collaboration looks like, what resources were in the community, what resources weren't in the community, and of course, how we could work together to make a difference. So that was like a really huge step for all of us from all these different sectors. But there were so many moving parts when it comes to dealing with a patient's journey. So learning about what those strengths were in the communities was really impactful for us. The strengths that support that person on the journey. Like we were all coming from different sectors. Not everybody deals with clients, so it was really good to learn about that. When we started mapping out the strengths, the services, and the supports, that's when the partners from different sectors that weren't necessarily in the health sector started to learn what impacts financial strain actually has, and the role that each sector can play, whether it was big or small, and just how we could tackle it all together. And I just remember when we had everything laid out, all of those strengths and services and supports, we were just really amazed just how rich those resources were that we had discovered as a small community. And another thing that we were really reflected on, Shauna, was just around reducing stigma about accessing these services, especially in a farming community where those the pride and just that independence of taking care of your family is really valued.
Mm-hmm. Yeah, and Scotty, you really reinforced that in your story. We can pop that in the link. You give some tips for health providers is that get rid of the stigma. So key. So Catherine, were there any aha moments for you as you listen to community members and partners?
Definitely, Shauna. I had quite a few of them. I had the opportunity and privilege to interview Creanne for her digital story, which was entitled Blindsided. And I really encourage anybody on the call here to go to take a look at some of our digital stories that were created and share them with your teams. Because what she spoke about was following through on some of those medical I guess, advice that she was given and just how she couldn't do it due to financial reasons. And like her story, like many others, it really illustrates and like Lisa said earlier about that need to connect across systems, across sectors. We need to be able to start closing some of those gaps along the patient journey so they don't fall into that silo effect. And we need to eliminate that silo effect. I mean, her health teams were working together with her, but when you're working in silos, I mean, we know we talk about it all the time, but we always seem to fall back into it. So another thing I really learned, another aha moment for me was really about collaboration and having the right community partners to lean on. And that's really what made this project a huge success. Another huge thing we heard from our partners across the board was that those social risk factors, which we heard from other people earlier today, they can come and go, but anyone, absolutely anyone can experience financial strain. And I know when we first came to the table, we're like, how can we impact someone's financial strain, right? And then the pandemic hit and we all just like, our mouth jaws dropped and we're like, absolutely anybody can experience financial strain. But coming together, like getting back to that collaboration and the right community partners coming together to solve this complex, huge problem, it really had more impact as a collaboration.
Mm-hmm. Yeah. Oh, so powerful.
Yeah.
Well, thank you all to our panelists. I hope you can help us with some of the questions from the audience. So if you have any questions, please put them in the Q&A box. And we invite your thoughts and reflections in the chat box. We've got one question here from Sandra. And she's been one of our amazing patient family advisors for this work. And she's wondering, when is it going to be out in her zone and see some of the changes and help to those that need it in other zones other than where this work was done. So is there, I don't know if someone wants to respond to that. I know we've had some exciting announcements from the government. Laura, Lisa, do you want to jump in on that question?
I could start and others may want to weigh in. We do know, as you've pointed out, that in the whole review of modernizing primary care, this project actually really stood out to the government as they were thinking about ways to really do primary care differently. And there's a very strong interest in moving forward with a scale-up rollout plan that would actually get embedded into the whole modernization process for primary care. So I don't think we can probably give you too many concrete details, but just say, stay tuned. This has really attracted a lot of attention. And I think both the primary care teams and the public health teams are very much committed to helping make sure that this is available across the whole province through all PCNs and connected to as many communities as possible.
Yes, and I think that kind of answers the next question around what about those family docs that are not involved in a PCN and how are they being included? And so I'm guessing that would sort of encompass that.
Yeah, exactly. I mean, to the extent possible, the idea will be to any of the tools, the learnings, the approaches, really trying to have them all available on the RIF site so that, there's not such a dependency on the teams that were helping to build this out, and that this really becomes a bit of a collaborative practice, that as we learn going forward, we keep sharing the tools and the resources, and we're hoping that we can make that space for, as people keep learning, as you're implementing and taking this forward, that you're adding to that knowledge base, and it becomes a bit of a self-serve opportunity and a way that we can share between us.
Mm-hmm. Yes. The next question is around financial strain and the choice of the language. I'm wondering, Lisa, if you can jump in on that, and why the word financial strain was used.
Sure. I mean, I think when you look at the screening tool, it talks about, do you have challenges making ends meet at the end of the month, which really is a subjective question in many ways that could be answered in that way by many people. While it does have good sort of sensitivity to identifying those who are experiencing poverty, which is an objective measure, it also is more inclusive to include anyone who really is struggling at that time. So financial strain from a subjective perspective is more inclusive. I also think that when you look at it from a community perspective around ideas of promoting financial well-being and wellness, that also it can be more inclusive as well. So while there's links to, poverty reduction strategies and identification of poverty per se, the choice to use financial strain was really around, I think, the link to the language that's used, but also that inclusivity that we know that anyone in Alberta could experience financial strain at any time in their life. And
Right.
It's a way to include everybody in the conversation. So once again, potentially reducing some of that stigma, because this can affect all of us at any time in our lives.
Mm-hmm.
Yeah, and maybe I can just add just really quickly, 100% agree and endorse everything, Lisa said. The original tool that primary care and some of the colleges were using was called the poverty screening tool. And as Lisa was saying, it just didn't really capture this essence of sometimes transitory nature of financial strain, and that sense that this could be anybody, as I think Scotty's story just tells so well. So that really was the idea.
Yeah, absolutely. So Charlotte, maybe that's a good question for you. There's a question around how clinics have found ways to include this, considering the pressure and demand put on them by the government, restricting the type of appointments that they can be billed for by physicians, for example, often can only accept one issue at a time.
Yeah, so that was kind of part of that, having the laminated sheet with the questions so that the physician could acknowledge the fact that there could be a problem, whether it be housing, whether it be food, whether it be medication. There's all kinds of reasons why. And so what we did then was we have our primary care staff work within the family physician office. And so then the physician would do their part and take the client down to see the nurse at that time. And then the nurse could try and sit and talk with the patient a little bit longer, had a bit more time, could figure out what the urgent issues were at the time, and then try to find resources available. Since doing RIFs and starting the program, we've, like I said, hired a mental health navigator. But after that 6 months, we found that some people wouldn't answer the phone. So we changed the name to Community Support Navigator. So now our physicians make appointment with that Community Support Navigator, and those patients are helped that way.
Awesome. So there's a couple questions that are looking at, kind of the elephant in the room with regard to the need for more upstream action and a healthier public policy, and some at the government level. And that Scotty's story kind of highlighted the need for some of those higher levels of income support, pharmacare, affordable housing. So how might we, I guess, kind of collectively as a province, as providers, as a health system, as community partners, advocate for those kind of changes? And I'll just throw in there as well the role of the social worker in some of this work. So I don't know if someone wants to, in the next 1 minute, just take that question on before we wrap up.
Just quickly, I can say, from a community environment perspective in municipal government, there are certain strategies that you can take that are really upstream and looking at the municipal environment. But I totally agree with you. A lot of the policies and supports really need to be integrated across different levels of government. We did partner with the University of Alberta around the creation of a sort of public health policy resource guidebook, and I'll pop that into the chat. But I think, the second part of the comment around partners taking on, roles to be able to promote this work and really work together across government is going to be critical to kind of shift that mental model, shift those mindsets, and create those supports that are needed at higher levels as well.
Yeah, thank you so much. There's so many questions, great comments as well. And this is really just the taste of some of the opportunities and actions that we can take. And so in just the last few minutes, I want to highlight some of those actions and resources and challenge you to really look at what can you do as a team? How can you dig into this? We would love to have more richer conversations with any of you that are interested in this field. But one thing, take a digital story to the next conversation with your team, watch it, discuss, and just explore where this can go as a team in learning more about advancing health equity, addressing social determinants of health within your role, within your team, and as a collective locally. And then think about, how can I broaden my team? What are these other sectors and community partners and community members that I can include in our team? There's power in that collective. And just start talking. How can we start the shift? And as Charlotte said, start small, test a change and adapt over time. So we've got lots of resources that you can tap into, and we'll be sharing those out in the email you'll get following this session. Just to quickly highlight a few, you can see there's some infographics, there's the screening tool that was the intervention tool, the clinical tool that health primary care providers used. There's a way of planning services using the population health needs framework. There's a whole lot of change packages and training and support that the Alberta Medical Association has developed with these primary care network teams. And Lisa just mentioned the financial wellbeing toolkit. As well, we really encourage you to take a look at all the related training and supports like 211 and trauma-informed care. So lots of options, and certainly reach out to us if you have any other resources and questions about any of these. So just as a wrap up, I want to just acknowledge that this has been just a couple of the people representing this work. There's so many other players that have been involved, and so many other teams that have really participated in this work, and we want to give them a big shout out and thanks. We also want to give a big shout to our patient family advisors, and Scotty, thank you so much for all your contributions. And I just want to now pass it over to the organizing group. Thank you.
Thanks, Shauna. Thanks, panelists. Thanks, attendees and everybody who was so keenly involved. And today it was a fantastic topic and lots of questions. What happens next is we will do a follow-up email that should come out today or tomorrow with those resources. And then once the recording is posted, we'll send out another email just to let you know where that is. I think there were some questions unanswered, so we're hoping that we could maybe do a quick send out of a few of those answers as well. And of course, we'd love to hear from you about what you thought about today. We will have our contact information in the email. So if there's questions that need follow-up, please contact us or Shauna and her group. And look for opportunities coming up. We'd love to see you on our next webinar and events. So you can click on the link here. You can take a look or take your camera and take a picture of the QR code for a quick eval. Really, it's take you just a minute or so. And we will send that out as well in the email. So we're right on time, and I really want to thank you, and we look forward to seeing you again at our next webinar. Enjoy the day.